Welcome to the clinical anatomy section on the upper limb, which will include 2 lectures. The upper limb is divided into 4 segments. From the shoulder down to the hand, they are the shoulder, the arm, forearm, and hand. The shoulder refers to the deltoid, as well as the pectoral, scapular, and lateral cervical regions. The shoulder includes the pectoral girdle. The pectoral girdle refers to the ring around the upper thoracic region. This includes the scapula, the clavicle, the manubrium, and then going over to the other side, the other clavicle, and the other scapula. So it literally forms a circle around the upper thoracic region, but it is incomplete posteriorly. Because the 2 scapula are not connected to each other, the ring does not completely circle around the back. The pectoral girdle forms the 2 shoulder sockets on the sides where the arms or upper limbs connect to the thorax. Moving down or distal from the shoulder is the arm. The arm is the area between the shoulder and the elbow. It's an area that's centered around the humerus, and it's divided into anterior and posterior regions. The anterior regions contain the flexor muscles. The posterior regions contain the extensors. The forearm is the antebrachial area, or the area between the elbow and the wrist. The forearm contains the radius and the ulna, and it's also divided into anterior and posterior regions. Again, the anterior regions contain mostly flexors, and the posterior regions contain mostly extensors. The hand includes everything distal from the wrist. So the wrist, the palm of the hand, and then the back or dorsum of the hand, as well as the digits or fingers. The hand is densely packed with sensory endings for touch, temperature, pain, all of the general senses. This makes sense when we think about the fact that our hands are our primary tools that we utilize for dexterity, so they do need to be more sensitive. You guys are learning the bones of the upper extremity or the arm in lab. So we're going to jump right into clinical conditions that affect the bones or related to the bones of the arm. We'll start with fracture of the clavicle. The clavicle or collarbone is frequently fractured. Often this is the result of somebody falling and trying to catch themselves with their arms outstretched. The force of that fall can be transferred throughout the bones of the arm and into the clavicle. And it fractures the clavicle at the point where the medial and lateral thirds meet. Also, a direct blow to the shoulder can end up putting force on the clavicle and fracturing the clavicle at the same point. So if you think about the fact that the clavicle goes from the manubrium on its medial side to the acromion of the scapula on its lateral side, and divide that up into thirds, and then where the middle and the last third meet, that point is the weakest point on the clavicle. That's the point that typically fractures. When the clavicle fractures, the bones don't stay in line. The medial portion of the bone, the part that's attached to the manubrium, typically goes up, and the lateral part of the bone goes down. And then the lateral part often gets pulled in so that the two fragments or the 2 parts of the clavicle end up sitting kind of on top of each other like this. So the reason for that is because of the muscles that are attached to the bones. So thinking of the medial fragment or the part that's close to the manubrium, remember that the sternocleidomastoid attaches to both the sternum and the clavicle. So the sternocleidomastoid has elasticity in it. It has internal tension in it. And that pulls the medial fragment upward. Right? There's no more resistance holding it down, so it rises. Now the trapezius, the muscle, the trapezius is connected to the lateral fragment of the clavicle. And there is some internal tension there to pull the lateral fragment up. However, the weight of the arm is so heavy that it pulls that lateral fragment downward, right? The trapezius is not strong enough to overcome that weight. So the medial fragment goes up and the lateral fragment goes down. So the shoulder ends up sagging on the side of the fractured clavicle. Also, the muscles that adduct the arm, where adduction is pulling in towards the midline, the muscles that adduct the arm can pull the lateral fragment in medially. So not only does the lateral fragment go down, but it gets pulled in towards the center. And that's why I said that the two fragments end up overlapping each other. And you can see that here in both of these pictures, right? The medial fragment of the clavicle gets raised up, the lateral fragment gets pulled down and inward, and you have this zone of overlap there between the two. These fractures frequently need to be stabilized with a plate and screws to realign the two fragments of the clavicle until they can heal. The clavicle begins ossification in the shaft at 5 to 6 weeks of embryonic development. So this is really early. It's one of the initial bones that begins to ossify. And it has a couple primary ossification centers in the shaft of the bone. Later on, there are secondary ossification centers that can show up and start to develop at the epiphysis, or the end, specifically the sternal end of the clavicle. Hey, this typically fuses with the shaft by 31 years of age. There are multiple variations that can occur in this ossification, though. Sometimes instead of just the epiphysis or the widened end on the developing on the sternal end, another secondary ossification site or another widened epiphysis can develop at the acromial end as well. So if there's another secondary ossification site back on the acromial end, you're going to see the line between the epiphysis, that secondary site, and the shaft of the bone. And that can sometimes appear as a fracture on an x-ray. Also, sometimes as the ossification centers are solidifying, there can be a bony deformation that forms between the medial and lateral thirds. So between the medial third and the lateral third. So this protrusion, the little defect, can also look like a fracture. Now this placement is kind of tricky because remember, this is the exact spot where we said the clavicle typically fractures. So when you see something that looks like a fracture and it's in the perfect spot that a fracture would be in, it's easy to just hop on it and say, yeah, this is a fracture. So this bony deformation is something to be aware of. If you're stuck and you're not sure if this is a fracture or not, you can go ahead and fracture the other clavicle. The reason for this is that this bony deformation is typically a bilateral defect. It typically occurs on both sides, whereas trauma that fractured the clavicle is not going to be occurring on both sides. A fracture won't be on both sides. So if you x-ray the unaffected side and see the same deformation or the same anomaly that looks like a fracture, then you know that your affected side is not actually fractured. Here we see the scapula or shoulder blade. The scapula, you can see the acromion up here is a process that articulates with the clavicle. The coracoid process does not form an articulation. This is just there for muscle attachment. You see the overall body as well as the neck and the head of the scapula. And here the glenoid cavity is where it forms a joint with the head of the humerus. Fractures of the scapula are pretty rare. It takes a pretty severe trauma to fracture the scapula, and part of that is just because of its location and the fact that it's so incredibly surrounded and encumbered by muscular structures, and it's really protected. However, the acromion, right, this process right here that articulates with the clavicle, is the most kind of at risk part of the scapula. It sticks up and out the most, so the acromion is the area that is the most common fractured site. Again, this still requires pretty severe trauma though. The scapula is fractured in severe accidents like pedestrian vehicle accidents or really severe motor vehicle accidents. When the scapula is fractured, it's typically treated relatively conservatively. The reason for this is that, again, the scapula is very enclosed in muscles. It has many muscles that cover both sides of it and wrap all around it. So it's held in place really well without the need for surgery or pins or screws to hold the pieces in place. Again, this is typically, sometimes a completed fracture can be so bad that it does require surgery, but the majority of scapular fractures are treated conservatively. Injury to the long thoracic nerve can paralyze the serratus anterior. When the serratus anterior is paralyzed, taking away that medial tension allows the medial border of the scapula to move out laterally and posteriorly. So the scapula, the medial border, which you see right here, okay, should be relatively flush or just a little bit visible on the back. But when it moves towards the back and out towards the side, it gives the appearance of a wing on the back. Hence the fact that we call this deformity winged scapula. When the arm is raised, this is even more pronounced, but the patient can't raise their arm all the way. The reason for this is that the glenoid cavity, remember the little depression where the head of the humerus fits in? The glenoid cavity can't be rotated superiorly. So if it can't be rotated superiorly, that prevents the humerus from being completely abducted. So remember, abduction is moving the arm away from the midline, right? So like raising the arm up. The arm can only be raised to the horizontal plane because of the lack of rotation of that glenoid cavity. But again, here you see on this side, this is the affected side or the side with the winged scapula. The rotator cuff muscles are the 4 intrinsic shoulder muscles that form a cuff around the glenohumeral joint. The glenohumeral joint is the shoulder joint, the joint between the head of the humerus and the glenoid fossa, the depression in the scapula where the head of the humerus fits. The rotator cuff muscles rotate the humerus, right? So a rotation at the shoulder, and then they also stabilize the joint. They help to hold the head of the humerus against the glenoid cavity during movements. SITS is the acronym to help you remember the rotator cuff muscles. Supraspinatus, infraspinatus, teres minor, and then subscapularis, that sits right underneath the scapula. So if you look at like the back of the scapula, above the spine is the spine of the scapula is the supraspinatus. Below the spine of the scapula is the infraspinatus. Right below that is the teres minor, and then underneath the scapula is the subscapularis. All but the supraspinatus. So the infraspinatus, the teres minor, and the subscapularis, all of these act to rotate the humerus. The supraspinatus assists the deltoid in the very beginning of abduction. So if this is normal arm position, abduction is raising the arm up, right? Like you abduct. The first 15 degrees of abduction is assisted by the supraspinatus. This will actually be important a little bit later clinically. Rotator cuff injuries can occur for lots of different reasons, but any traumatic injury or degenerative injury or disease that affects the rotator cuff muscles can effectively destabilize the glenohumeral joint or the shoulder joint. When we talk about rupturing of the muscles or tendons, rupture of the supraspinatus tendon is the most commonly affected. Also, degenerative tendonitis is relatively common. This occurs or is much more common in older adults. Fractures of the humerus can occur at multiple different levels or different areas of the humerus, and the specific implications of that fracture differ depending on where the fracture occurs. There are quite a few nerves that are in close contact with the humerus, so depending on where the fracture is, different nerves of the arm can be affected. A fracture of the surgical neck occurs at the proximal region or in the proximal region of the humerus. If you look over here at the humerus, the head of the humerus is this rounded area that forms the joint with the glenoid cavity or glenoid fossa. You see the two tubercles or kind of rounded protrusions from the bone, the greater tubercle and the lesser tubercle. This area in between the head and the tubercles, so this little thinned out area right here, this is the anatomical neck. The anatomical neck can be fractured, but it's not as frequently fractured as the surgical neck. The surgical neck is this thinned out area right here. Okay, so number 4 is showing you a fracture of the surgical neck. The surgical neck is a thinner, right? It's not as thick of a bone, and that is more commonly fractured than the anatomical neck up here. The surgical neck is commonly fractured in elderly women with osteoporosis. The osteoporosis slowly eats away at the bone mass in the area, making it weak. And then this happens to be a weak point or a thin area of the bone where a lot of force is applied when there's a fall. So the surgical neck is commonly fractured when an elderly woman falls and tries to catch herself with her hands. This can be even a really low energy fall. So it doesn't have to be like a huge impact. Just a little tumble can result in a fracture of the surgical neck. The axillary nerve does pass through or pass by the humerus really closely at this area. So axillary nerve damage is a common complication when there's a fracture of the surgical neck of the humerus. When we look at the distal humerus, so here you can see the distal humerus where it forms a joint with the ulna on this side and the radius on this side. Looking at the distal humerus, there are medial and lateral epicondyles. So like this up here and then over here are the median and lateral epicondyles. And these, we can have fractures just above the epicondyles, which we'll talk about in a second. And then also you'll see the processes, right? So the capitulum is this rounded process right here. And then the trochlea is this process right here. And you'll see that the median nerve passes in close proximity to the trochlea, and the radial nerve passes through right here in a little depression known as the radial groove. Also over here is the ulnar nerve. So the median nerve, radial nerve, and ulnar nerve are all in very close proximity to the elbow joint and can all be affected when there are fractures in the elbow region. A transverse fracture is a horizontal fracture that occurs in the shaft of the humerus. This typically occurs because of a direct blow to the arm, and the fracture would just occur at whatever area of the shaft the blow came to. A supraepicondylar fracture, again, is a fracture that occurs just over the epicondyles, so just around this region here. This is, again, in the distal arm right near the elbow. These can be on the ulnar side or on the radial side. The radial nerve, again, comes through in the radial groove right here. So a fracture above the lateral epicondyle would possibly damage the radial nerve. A fracture above the medial epicondyle is likely to damage the ulnar nerve. The radius and ulna are also fractured relatively frequently. Fractures of the radius and ulna are also relatively common. Colles fracture is the most common fracture of the forearm. This typically happens when, again, you fall and try and break the fall with your hands, try and catch yourself, and there's forced dorsiflexion of the, not hand, forced dorsiflexion of the hand, not head, as you try to break a fall. So the hand is dorsiflexed as you fall, and that presents pressure on the radius, which is on the thumb side here, of the forearm. When there's a Colles fracture, the fracture is in the distal, so that the last couple centimeters of the radius. This is often results in a comminuted. Comminuted is broken into pieces. So comminuted, or a distal radius, it's broken into pieces, and the distal fragment is typically displaced dorsally. So the small distal fragment of the radius sticks out towards the back of the hand. So there's like a hump sticking up like this way dorsally towards the back of the hand by the wrist. There's like this weird curvature, a dorsal curvature of the wrist and hand. Typically with a Colles fracture, the ulnar styloid process is avulsed or broken off. As well. And again, because when you fall and catch yourself with your hands and the hand is overly dorsiflexed, that's not only going to put pressure on the radius, that's also going to put pressure on the ulna as well. And the ulnar styloid process is that last little tip that sticks off at the very dorsal region of the ulna. When we look at the styloid process of the radius and the ulna, typically in a healthy forearm, the radial styloid process extends more distally. So the radial styloid process goes down a little bit further than the ulnar styloid process. When there's a Colles fracture of the radius, however, we see that the styloid process of the radius and ulna are level. So because of the fracture, the radius has been shortened a little bit, and it's now at the same level as the ulnar styloid process. Colles fracture results in what we call the dinner fork deformity. Again, there's this posterior angulation of the wrist. So the wrist is more angled towards the back, or the posterior side, and the resting hand looks like kind of like curved like a dinner fork. I'll show you a picture in just 1 second. Fracture of the distal end of the radius is the most common fracture in people over the age of 50. So again, a relatively common fracture. If there's a direct blow to the forearm, that typically produces a transverse fracture, so like a horizontal fracture at the same level that the blow is. So here we see that posterior angulation of the wrist and curved hand that creates that dinner fork deformity. Again, we see that with Colles fracture. So the distal couple centimeters of the radius has been fractured and distally displaced, or sorry, and posteriorly displaced. We'll talk about a few different fractures that can occur in the wrist and hand, fingers. Scaphoid fractures occur in the wrist. The scaphoid is one of the 8 carpal bones. The scaphoid is on the thumb side, so the radial side, and it is one of the proximal, or the first proximal carpal bone. So you see right here, there's a proximal row of carpal bones and then a distal row of carpal bones. And this is the thumb side here. This is the first metacarpal, which is on the thumb, and then this is showing you the distal radius. Scaphoid fracture frequently occurs when there's a fall in the palm with the hand abducted. So the hand is abducted like so, and you try and catch yourself when you fall. So the lesson from all of this is that reaching your hands out to catch yourself when you fall is not a good idea, because there's fractures that occur pretty much everywhere, from the hand up to the collarbone. So tuck and roll. Anyhow, typically when the hand is abducted, you try and catch yourself and you fall, you can fracture the scaphoid. Pain with the scaphoid fracture typically occurs in the wrist and the snuff box. In the very beginning of the semester, we looked at the snuff box, but if you go like this with your hand, you can see on the lateral side of the hand, this region right here, right in this little triangle, that's the snuff box. So when the hand is abducted, right, fingers out, and dorsiflexed or flexed towards the dorsal side, there's typically excess pain here in the snuff box. Initial radiographs might not show a fracture. The fracture is really hard to see initially, but after bone resorption occurs, the fracture can be seen on radiographs. So it might take 10 to 14 days before the fracture is actually visible. So until then, you can go just based on patient history and then findings in the physical exam based on pain in the area. Healing in the scaphoid is typically relatively prolonged. There's a poor blood supply in the area, so healing takes time, and it can take several months for the fracture to heal. Avascular necrosis of the proximal segment is possible. Again, because of the poor blood supply, the tissue can get necrotic. If there's avascular necrosis, this can end up leading to degenerative joint disease of the wrist. The hamate is another one of the carpal bones that's also fractured frequently. When we're looking at the carpal bones, again, I said that we have 4 proximal carpal bones and 4 distal carpal bones. The scaphoid was proximal and on the thumb side or the radial side. The hamate is literally opposite of that. The hamate is the carpal bone that's in the distal row, and it's on the pinky side, or the ulnar side. When we look at the hamate, you guys will see that there's this process called the hook of the hamate that's pretty visible, and it extends towards the palmar side, not dorsally, but towards the palmar side of the hand. Here you can see it here. So in this picture, we're actually looking at, like you're looking at this part of the hand, the palm side. This is the hamate, and you can see the hook right here. The hook of the hamate is commonly fractured just because of the way that it sticks off from the bone. This can be problematic because here you see the ulnar nerve. The ulnar nerve is in really close proximity to the hamate and especially to the hook of the hamate. So fractures in this area can damage the ulnar nerve. When the ulnar nerve is damaged, this results in decreased grip strength. So you can test the grip strength in the 2 hands and compare them. If one is markedly decreased, that's possibly because of damage to the ulnar nerve. When the hamate is fractured, frequently the fractured parts don't heal back together again. They don't ever reconnect. And the reason for this is because of the traction of the attached muscles. So if the bone is completely fractured, it can actually be pulled apart by the muscles that are attached. And then the broken sides will heal, but they won't actually reconnect to each other. Also, the ulnar artery is in close proximity to the hamate as well, and that can also be damaged when a fracture occurs. The clavicle can be palpated along its length. So starting from the jugular notch, if you go just lateral to the jugular notch, you can feel the sternal end of the clavicle. Right, so the sternal end of the clavicle is right on the side of the jugular notch. And then you can just follow, you can palpate or follow the clavicle all the way over to the acromial end, which is where it attaches to the acromion of the scapula. The acromial end is typically, it rises just a little bit higher than the acromion. So if you follow it over, you'll feel a slight elevation and then it drops down to the acromion. That slight elevation is the end of the clavicle, the acromial end of the clavicle. That's right where the acromioclavicular joint is, and that's the end of the clavicle. Then you get to the scapula. So you've got the two processes on the scapula, both of which you can palpate, right? The acromion and the coracoid process. And then posteriorly, you can palpate multiple of the different regions of the scapula. So the acromion, first off, we just found, if you just trace the scapula, you just trace the clavicle, right, all the way back, again, you'll feel a slight ridge, right, where it elevates or goes up. That's the very end of the clavicle. And then you drop back down, and that's the acromion. The acromion is the lateralmost protrusion in the shoulder. So if you palpate the lateral edge of the shoulder here, the bony protrusion, that's the acromion. In a second, we'll look at the spine of the scapula, but if you just follow the acromion around back, you'll feel a ridge that extends in towards the center of the back. That's the spine of the scapula. So we know the acromion here, and we followed our clavicle. We had a little elevation, and then it dropped down to the acromion. If you find that elevation and then go just inferior and lateral to that, okay, so slightly inferior and lateral, and palpate deep. You got to push deeply. You'll feel a bony protrusion there sticking out. That is the coracoid process. The coracoid process, remember, is that like little hook-like process that sits underneath the acromion. So found the acromion, drop down and push deep, and you'll feel the coracoid process sticking out there. The spine of the scapula is easily palpated. Again, if you go just back and around from the acromion, you'll be at the top lateral portion of the spine. So the spine of the scapula travels immediately towards the center at a slight inferior slope. Right? So it goes kind of obliquely like this. Once you get to the root of the spine, you can start to palpate the medial border. So you follow the spine all the way in towards the center, it ends at the medial border. Then you can palpate the medial border all the way down to the inferior angle. The inferior angle, little like downward point at the bottom of the scapula, is very easily palpated. You could typically even see it. The lateral border you cannot easily feel. The lateral border of the scapula out here is covered by the teres major and teres minor, so it's really difficult to palpate that well. There are multiple points on the humerus that can be palpated, starting on the proximal humerus. Remember, the head of the humerus connects to the glenoid cavity, or fits into the glenoid cavity, and then kind of more anterior and lateral to that are the tubercles. There's a greater tubercle, a large kind of lateral process, and then a lesser tubercle, which is more anterior. Both of these can be palpated. The greater tubercle can be palpated just, it's deep to the deltoid, and it's a little bit lateral and inferior to the acromion. So the acromion, remember, we felt like right at the top of the shoulder right here. If you go just lateral and inferior to that, you can feel the greater tubercle. It's larger and less angular of a protrusion. You can feel it when the arm is resting at the side. It cannot be felt when the arm is raised. Not when arm is raised. because the greater tubercle actually, it slides or goes under the acromion when the arm is raised, so it can't be felt then. It's lateral out here, whereas the acromion is higher up right here. The lesser tubercle can be palpated with deep palpation. You have to find the coracoid process first. So remember, to find the coracoid, we traced the clavicle over, and the elevation was the acromial end of the clavicle, right by the acromion, and we dropped down from that, right, and right there I can feel like a strong bony protrusion. That's the coracoid process. To feel the lesser tubercle, which is part of the humerus, the arm, you go just lateral and inferior to that. Right? And it's deep pressure, so push in and kind of laterally towards the humerus. And I can feel a little process, a little protrusion there on the bone. If you're not sure if you have it or not, rotate the arm. If you rotate the arm back and forth like this, and you can feel the rotation of the lesser tubercle. That lets you know like that's what it is. So rotate. Rotating the arm allows you to feel movement of the tubercle. And that allows you, like that tells you, yes, you're actually touching it. It kind of hurts right now, but you can feel it when you're rotating your arm, if you're not feeling the movement, you're not touching it. On the distal humerus, right, so that was the proximal humerus. If you follow the humerus down to the elbow, the distal humerus, you can feel the epicondyles, right? So the epicondyles are on either side of the elbow, right? Like these little bony protrusions. I don't know if you can see mine, right here and here. You can probably feel yours really easily. Just bend your arm like this and feel the sides of your elbow. Right? Those are the epicondyles. There are also multiple bony prominences that can be felt in the forearm or the antebrachial area. The olecranon of the ulna is easily seen and felt. The olecranon is like this most bony protrusion here of the elbow. When the arm is straight, the olecranon is in line with the epicondyles, right? So like the epicondyles, right, the bony protrusions on the sides, in the olecranon. When the arm is straight, they are in a straight line with each other. When the arm is bent, they form a triangle, right, with the olecranon being the apex, because there's a straight line between the epicondyles, and then they form an apex at the olecranon. So this bony protrusion is the olecranon. The head of the radius can be palpated on the posterior lateral aspect of the extended elbow. So extend the elbow, and you can feel this just distal to the lateral epicondyle, right? So the epicondyles are these like bony protrusions on the side, right? If you go just distal or just closer to the hand from the lateral one, this is on the thumb side, and then rotate. Right? When you rotate, the head of the radius rotates, so you can feel that process rotating as you twist your arm back and forth. So you know that you have the head of the radius there. The styloid process, right here, sorry. The styloid process of the radius can be felt in the snuff box. Remember the snuff box? If you abduct your fingers like this, you can see the snuff box right here. So if you palpate in there, you can feel a bony protrusion sticking out. That's the styloid process of the radius. The head of the ulna is easily visible and palpated. That's this bony prominence that's here on the pinky side, the distal pinky side of the arm, right here. There are multiple bones and prominences that can be palpated on the wrist and the hand. On the palm side of the hand, so on the palm, pinky side of the hand, you can palpate the piriform, which is one of the carpal bones, and then also the hook of the hamate. So again, palm side, pinky side, when the hand is completely at rest, you can actually like wiggle and move. The piriform, which it's actually shown here on the palm side, but like right in this area, but on the palm side. So like right here, you can actually wiggle it and move it when your hand is relaxed. If you go just lateral to that, so just distal and lateral to that, you can actually palpate the hook of the hamate. Right here, so I palpated the hook of the hamate right there, and I can feel the nerve, the ulnar nerve passes right through there, and I can feel like that I'm compressing it. The tubercle, the scaphoid, and trapezium can both be palpated medial to the ball of the thumb when the hand is extended. So extending the hand just medial to the ball of the thumb, you can palpate both of these tubercles. The metacarpals are easily palpated. So you've got 2 rows of carpals, so 8 carpals, and then these are your metacarpals, right? So enclosed in the hand, these are the metacarpals, 1 through 5. Number 1 is the thumb, and then 5 is the pinky. So 1, 2, 3, 4, 5, and you can feel them really easily. The distal portions of them, that's the head of the metacarpal, and that's what forms your knuckles, right? So the third metacarpal, the middle finger knuckle is normally the most prominent, but again, these are just the heads of the metacarpal bones. The bones in the fingers are referred to as the phalanges, and the dorsal, right, the back ridge of these bones is easily palpated or felt. Each finger has 3 phalanges except the thumb. So each of your fingers has proximal, middle, and distal. The thumb only has 2. So the thumb has the proximal phalanx and the distal phalanx, no middle phalanx on the thumb. Phalanx is singular, phalanges are plural. Again, the distal portion of the phalanx is also referred to as the head, and that forms knuckles. So your knuckles are the joints between the adjacent phalanges. We'll talk about the fascia of the upper limb, as well as the way that they enclose the muscles of the upper limb. Just deep to the skin is the subcutaneous tissue. The subcutaneous tissue is referred to as the superficial fascia, and this area contains a lot of fat tissue. Then deep to the subcutaneous or superficial fascia is the deep fascia. The deep fascia is the fascial layers that surround the muscles. The pectoral fascia surrounds or invests the pectoralis major. You see that over here in yellow. Right, so the pectoral fascia surrounds the pectoralis major, the pectoral region. Inferiorly, this fascia is continuous with the fascia of the anterior abdominal wall. Laterally, it becomes the axillary fascia when it leaves the lateral border of the pectoralis major. Deep to the pectoral fascia is the clavipectoral fascia. The clavipectoral fascia descends from the clavicle and invests the subclavius and the pectoralis minor, which sits right underneath the pectoralis major. Again, so this fascia is deep to the pectoral fascia, and the clavipectoral fascia is also continuous with the axillary fascia. So both of these fascial layers end up merging to go be continuous with the axillary fascia. In blue here, you see the clavipectoral fascia, right? So the subclavius is this muscle right here underneath the clavicle. You can see how it comes around there. Costocoracoid membrane is the specific part of the fascia, and then you can see it invests the pectoralis minor, and then it comes down to form the axillary fascia, And the pectoral fascia also comes in to form the axillary fascia. Moving into the upper arm region or the brachial region, the deltoid fascia invests the deltoid muscle in the lateral shoulder. The deltoid fascia is continuous with the pectoral fascia anteriorly and with the infraspinous fascia posteriorly. The brachial fascia encloses the upper arm like a sleeve, like a tight sleeve completely around the muscles of the upper arm down to the elbow. Inferiorly, it's attached to the epicondyles of the humerus laterally and to the olecranon of the ulna posteriorly. So this anchors the brachial fascia distally. From that anchoring portion, it then continues with the antebrachial fascia, which does the same thing, forms like a tight sleeve in the antebrachial area or the forearm. The brachial fascia has a medial and a lateral intermuscular septum. So there are two intermuscular septa that extend from the fascia in towards the shaft of the humerus and to the epicondylar ridges. These septa effectively divide the brachial compartment up into an anterior fascial compartment and a posterior fascial compartment. The anterior compartment holds the flexor muscles. I think the flexor muscles include biceps brachii, brachialis. The extensors, extension is primarily from triceps brachii, and that's in the posterior fascial compartment. So here we see this is a section of the upper limb. The humerus is the bone that runs down the center of the upper limb. You can see around the outside here, we have our brachial fascia. And then from the brachial fascia, we have these lateral and medial septa that divide the brachial region, the upper arm, into anterior and posterior compartments. So the anterior flexor muscles are in the front, and in the back we have the extensor muscles. Flexors, and then your extensors in the back. Again, the flexors in the front, you are the biceps brachii, brachialis. Oh, I forgot coracobrachialis. Coracobrachialis. See, those are all the flexors that are in the anterior compartment. The posterior compartment includes the extensors or extensor, which is triceps brachii. And these are completely separate from each other. They have their separate muscles, they have separate actions, and they have separate innervation. So, for example, the flexors are innervated by the musculocutaneous nerve. Okay, so the musculocutaneous nerve innervates the anterior compartment. The radial nerve innervates the posterior compartment, and so controls triceps braking. The antebrachial fascia is the deep fascial layer that surrounds the muscles of the forearm. When we look at the antebrachial fascia, again, it's divided into an anterior compartment and a posterior compartment. It's just divided a little bit differently than we saw up in the brachial region. There's the antebrachial fascia around the outside, which you see here, right? All around the outside is the antebrachial fascia. Then you see the intramuscular septa. So there's intermuscular septa on each side and an interosseous membrane between the bones that separates the antebrachial cavity into anterior and posterior regions. So you can see the intramuscular septum, right, extends in, but then you have the two bones of the forearm. And in between the radius and the ulna, we have the interosseous membrane. So between the septa and the interosseous membrane and the bones themselves, the antebrachial region is separated into anterior compartments and posterior compartments. And again, just like we saw in the upper arm, that ends up giving us flexion and extension, right? So flexion and extension. When we look at this antebrachial fascia, it thickens both anteriorly and posteriorly to form the extensor retinaculum and the flexor retinaculum. So posteriorly, over the back or dorsal region of the hand, this fascia thickens and forms the extensor retinaculum. So this is like a nice, like thick area that goes over and holds the extensor tendons in place. So the extensor tendons that come through and connect distally, they're held in place by this extensor retinaculum that sits over them or rides over them kind of like a belt, so that they can move, but they don't move out of place. Now this extensor retinaculum, which is on the dorsal side, continues anteriorly, but it does not flow directly into the flexor retinaculum. The extensor continues anteriorly as the palmar carpal ligament. Right, so if you look right down here, this is the palmar carpal ligament. Deep to that, the antebrachial fascia thickens anteriorly as the flexor retinaculum. Right, so you can see the flexor retinaculum that extends between the outer prominences of the lateral carpal bones. So it's attaching to carpal bone here and a carpal bone here, and it's extending across the palm side or anterior side of the wrist. Now, it's not flush or tight there. There's a little passageway underneath it. So the carpal bones are concave there. They cave in, right, like this. And then the retinaculum stretches across them. Sorry, that was bad. They cave in, and then the retinaculum stretches across them. So there's this passageway that's created between them, and that's called the carpal tunnel. So just underneath this flexor retinaculum is the carpal tunnel. And the flexor tendons and the median nerve pass through this carpal tunnel, right, to come out on the palm side of the hand. Hence carpal tunnel syndrome, which we'll talk about a little bit later. Okay, so here you guys can see those couple of things. This is showing you the dorsal side of the hand, right? The back side of the hand. And again, the antebrachial fascia, right? The sleeve that covers all of the muscles in the antebrachial region of the forearm thickens up at the wrist. On the backside or dorsal side of the hand, it thickens to form the extensor retinaculum. And all these muscles right on the back are the extensors. And their tendons come underneath the extensor retinaculum, and then you can see they extend down and they attach to the digits. So the retinaculum stabilizes those tendons. This is showing you the palm side of the hand, right, the anterior aspect of the hand. And on the anterior aspect of the hand, the deep fascia thickens to form the flexor retinaculum. Right, and you can see again it's extending from the trapezium, right, the carpal bone right here, over to the piriform, and then over here you see the hook of the hamate. Okay, so this extension is going across here, and notice if you can see there's room underneath it, and underneath it we have nerves and tendons, right? So the median nerve passes underneath here, right? And the flexor tendons pass underneath here as they head out into the belly or the palm of the hand. Again, that tunnel or that passageway is referred to as the carpal tunnel. The palmar fascia is the continuation of the antebrachial fascia past the extensor retinaculum and the flexor retinaculum. Past the retinaculum, the fascia continues for the hand and then eventually into the digits or the tendinous sheaths of the digits. The palmar aponeurosis is the central thick tendinous region. You can see here extending past the flexor retinaculum, how there's this wide, broad band, which again, remember we call an aponeurosis when instead of a tight banded tendon, it's a broad, flat tendinous area. And this extends again to the base of the fingers here, and then it continues down the fingers as the tendon sheaths of the digits. Cutaneous nerves relay sensations from the cutaneous regions of the arm. Most of the arm is served by the nerves of the brachial plexus. However, there is a small part of the arm, the shoulder region, that is served by nerves of the cervical plexus. The cervical plexus is formed by the anterior rami of the first four cervical nerves, so C1 through C4. C3 and C4 are the only ones that pertain to the arm. The anterior rami of C3 and C4 supply the cutaneous nerves of the shoulder, so touch sensations from the shoulder will be relayed to spinal nerve C3 and C4. This is via the supraclavicular nerves. Again, the rest of the arm is served via the brachial plexus. The brachial plexus is formed by the anterior rami of C5 through T1. So C5, 6, 7, and 8, and T1. Each nerve serves a specific region of the arm, and the area that's served by one spinal nerve is referred to as a dermatome. Now, there are a couple different dermatome maps, and the two dermatome maps are not the exact same. And it's important to remember that the borders between dermatomes are not concrete. There's some overlap involved, there's some variance involved, but the dermatome map gives us a general idea of which nerve is going to be relaying cutaneous sensations from which area. We already looked at these once, but we'll look at the dermatomes of the arm right now so that you're extra familiar with them. Again, we just said that spinal nerves, C3 and C4, relay sensations from the shoulder. Then we work our way down the lateral arm, the tips of the fingers, and then back up the medial arm to the axilla. So C3, C4 serve the shoulder. C5 is the lateral arm. C6 is the lateral forearm and thumb. Then the the middle and ring fingers, and then going up a little bit up the back of the forearm is C7. Then C8 is the pinky, right? And then up the medial side of the hand and forearm. And then T1 is up the medial side of the arm, right? And T2 gets into the axilla. Again, kind of depends on which map we're looking at. Here we see over here the dermatome maps. Yeah, again, C3, C4 in the shoulder. Okay, C5 is in the lateral arm. C6, lateral forearm and thumb, kind of towards pointer. C7 is a couple middle fingers and then a little bit up the posterior side or the back of the forearm. C8 is the pinky and up the lateral side of the hand and forearm. T1 goes up the medial side of the arm. And then again, it kind of depends on what map you look at. Sometimes T1 goes up higher than this, but you see T2 has some innervation in the axillary region. We typically include the up to T1 though when we're talking about the brachial plexus. Over here, you guys see the actual nerve there. This is just, the dermatome is just telling us the spinal nerve where those signals are coming from or going to. This map is showing us the specific nerve that's involved. So again, the supraclavicular nerve was here for C3 and C4. Okay, the axillary nerve, okay, the radial nerve, the medial cutaneous nerve, that intercostobrachial, medial cutaneous nerve of the forearm, musculocutaneous, the radial nerve, the median nerve, and the ulnar nerve. These we'll talk about later. I'll expect you guys to learn these later on when we look at the nerves of the arm. Venous drainage from the arm comes from two major sets of veins: superficial veins that are superficial in the subcutaneous tissue, and then deep veins which are inside the deep fascia and run alongside the major arteries of the arms. These superficial and deep veins are interconnected with each other. Perforating veins connect the deep and the superficial veins. So the superficial veins originate on the dorsal side of the hand as the dorsal venous network. Then from the dorsal venous network, the cephalic and basilic veins continue all the way up the arm. The cephalic vein ascends on the thumb side of the forearm and arm. In the subcutaneous tissue, again, lateral side or thumb side, and eventually it comes all the way up the arm. It passes between the deltoid and the pectoralis, and it enters and merges with the terminal axillary vein. So the very, very end of the axillary vein it merges with, and that allows us to form the subclavian vein. The basilic vein ascends in the subcutaneous tissue on the medial side or pinky side of the forearm and arm. It merges a little bit sooner than that, or it merges more distally. It pierces the brachial fascia, okay, so pierces the deep brachial fascia, and it joins with the brachial vein to form the axillary vein. So the basilic vein is merging sooner, and then the axillary vein continues to travel, and then the cephalic vein joins with the axillary vein a little bit later. The median cubital vein passes obliquely between these two. So it interconnects the cephalic and basilic veins on the anterior elbow or antecubital region. This is where you normally get blood drawn. It is right here, intercubital region, from that median cubital vein. The median antebrachial vein is a smaller vein that traverses up or ascends up the middle of the anterior forearm. So those are all the superficial veins. These are the ones that are really easy to see from the surface that we'll normally get blood from. The deep veins are located, again, deeper. They're internal to the deep fascia. They typically come in pairs. So there's 2 brachial veins, 2 radial veins, 2 ulnar veins, and they accompany the major arteries in the arm. So the 2 radial veins run up the thumb side on either side of the radius, right by the radial artery. The 2 ulnar veins run up on either side of the ulna, right by the ulnar artery. At the elbow, they join and become the brachial veins. The 2 brachial veins run up on either side of the humerus, right by the brachial artery. Again, these all end up joining together. Here you see this venous drainage. This one here, I wanted you guys to look at the ulnar and radial and brachial veins. Okay, those are showing you the deep veins. This is how you can see there's 2 of each, right? So there's 2 of these ulnar veins. They run up the ulna, 2 radial veins that run up the radius. They end up coming together at the elbow or the antecubital region. And then we have the brachial veins that run up by the humerus, right by the brachial artery. Over here, you can see that over here, you can see the deep veins, right? You have the radial, the ulnar, you can see them coming together at the elbow. You see the brachial, and the brachial comes up and eventually goes into the axillary. You also see the superficial veins really good on this one. This one's more accurate with the superficial veins. So here you can see the dorsal venous networks. And then coming up the thumb side of the hand is the cephalic vein. So, oh, this actually doesn't, this is showing you the palmar networks. But coming up the thumb side of the hand is the cephalic vein, right, all the way up the thumb side. Coming up the pinky side of the hand is the basilic vein, right, comes all the way up. Here you can see that the basilic vein merges with the brachial vein. That gives us the axillary vein. Then you see that later, right, a little bit after that, the cephalic vein jumps in with the axillary vein or merges with the axillary vein. Shortly after that, the axillary becomes the subclavian. Also the median cubital vein, you can see here, goes obliquely, connecting the cephalic to the basilic. And then the median antebrachial vein, you see it coming up right at the very middle of the forearm. The superficial veins of the arm are commonly used for venipuncture. Venipuncture is, we could be puncturing a vein in order to draw blood, or puncturing a vein in order to inject a solution, or long-term administration of medications or fluids or nutrition. But the superficial veins in the arms are commonly used for puncture because they're really easy to access. They're big, they're easy to visualize, they're easy to puncture. When we're accessing one of the veins of the arms, we typically will place a tourniquet on the upper arm, tie something tight around the upper arm, and that blocks the venous return of blood. When you block the venous return of blood, the blood accumulates in the vessels, and the vessels enlarge. They swell, and then they're bigger, easier to see, and easier to puncture. That tourniquet is removed once the vein has been accessed. Otherwise, when you remove the needle, it'll bleed profusely. So removing the tourniquet allows the venous return to continue to flow out of the arm, and then there's not that huge back pressure that would cause profuse bleeding when you remove the needle. The median cubital vein on the anterior elbow or antecubital area is a commonly used site. Also, the dorsal venous networks, so the networks of veins on the back of the hand here, as well as the cephalic and basilic vein. These are good sites if it's going to be a long-term introduction of fluids. The axilla is the pyramidal space that's inferior to the glenohumeral joint, so below the shoulder joint, and superior to the skin and tissue and axillary fascia at the junction of the arm and the thorax. So between the shoulder joint and the underarm, this is the axilla. The axilla provides a passageway for blood vessels and lymphatic vessels and nerves that are passing to and from the upper limb. The axilla has an apex, a base, and then 4 walls, anterior, posterior, medial, and lateral. The apex is formed by the cervico-axillary canal. This is the passageway between the neck and the axilla. It's bounded by the clavicle, the first rib, and the top of the scapula. So literally the hole or the passageway, the space that's available to go from the neck down behind the clavicle and into the axilla. So that's the apex, that opening. The base is just the concave skin of the axillary fossa. The axillary fossa is just, if you raise your arm, this fossa or this depression right here, which really you would just say the armpit. That forms the base or the very bottom of the axilla. The anterior wall or front of the axilla is the pectoralis major and minor. The anterior axillary fold, which is this fold of skin that's in the front of the underarm, marks the inferior most edge of the anterior wall. So the anterior wall is like right here to this fold. The posterior wall is bounded by the scapula and subscapularis, the muscle that sits right underneath or on the back end of the scapula. Or I guess technically it would be the front of the scapula. The posterior axillary fold, this fold of skin right here at the back of the underarm, marks the inferior most edge of the posterior wall of the axilla. The medial wall is just the thoracic wall and the serratus anterior that sits on top of it. And then the lateral wall is formed by the intertubercle sulcus of the humerus, so the bone that's actually most lateral. Here you can see the axilla, right? So here this kind of pyramidal shaped area. The apex again is this cervico-axillary canal. So this passageway, again between the clavicle, the first rib, and then the top of the scapula in the back. Medial border was up against the rib cage and the serratus anterior. The lateral border was this intertubercular groove of the humerus. The posterior border is the scapula and the subscapularis. And then the anterior wall here was formed by the pectoralis major and minor. Over here, this is the axillary fossa, this depression that's right here. That forms the base of the axilla. That's the very bottom of the axilla, and the axilla stretches up like this. And the anterior axillary fold is this fold of skin right here in the front of the fossa. The posterior axillary fold is this posterior fold of skin right behind the fossa. Again, the axillary fossa is the actual depression here. The axillary artery and vein are big vessels that pass through the axilla as they cross into the arm or the upper extremity. When we look at the axillary artery begins as the subclavian artery. So here we have the subclavian artery, and just past the first rib. So this is the first rib at the lateral edge of the first rib. So right here, the subclavian artery becomes the axillary artery. The axillary artery passes posterior to the pectoralis minor and enters into the arm. The axillary artery turns into the brachial artery just inferior to the bottom of the teres major. So once it crosses the teres major, it becomes the brachial artery. So subclavian up here, brachial artery down here in the arm. In between, going through the axilla, is the axillary artery. The axillary artery is divided into 3 regions. The regions are just based off of the pectoralis minor. Remember, we said it passes just underneath the pectoralis minor. So we use the pectoralis minor as like a barrier or a way to cut the sections into 3 sections. So the 3 regions are the first, second, and third. The first region here is the region before it gets to the pectoralis minor. The second region is the region that's behind the pectoralis minor. And then the third region is the region that's after the pectoralis minor. These are the main branches of the axillary artery. The numbers that I have after them are telling you the segment of the axillary artery that it's coming from. So the superior thoracic artery comes from the first axillary segment, and you can see it right here. Superior thoracic artery. The next 2, the thoracoacromial and lateral thoracic, are both coming from the second region. The thoracoacromial artery comes off of the axillary, and then it has, and then it branches many times almost immediately. So it's a pretty short segment. And then you see it goes over to the deltoid, it goes up to the acromion, it goes to the axilla, it goes to the pectoral region, it branches everywhere. But the thoracoacromial artery is just like that first little part there. The lateral thoracic artery is at the end of the second segment, right here. So superior thoracic is up here, lateral thoracic is right here. The subscapular artery comes from the third region, right here, subscapular, right? You can see it come underneath the scapula. And then the circumflex humeral arteries, there's actually 2 of these, and they circle around the humerus. So there's an anterior circumflex humeral artery, which is coming around the front, and a posterior circumflex humeral artery, which is wrapping around the back of the humerus. Clinical impact here, when we talk about the axillary artery, if there's profuse bleeding in the arm, then it can be important to compress the axillary artery to slow that bleeding. So bleeding in the distal portions of the arm can be slowed by compression of the third part of the axillary artery against the humerus. So here again, looking at the axillary artery, this is the first rib. So it begins just distal to the first rib, continues, it goes underneath the pectoralis minor, right? And then it flows into the brachial artery. So if you look at this, if you go up into the axilla, you can actually push, so from the angle where this arrow is, you can actually push the axillary artery against the humerus and compress it. And you can feel it, like if you push up into the like kind of bottom of the axilla with deep palpation in the axillary fossa, you can feel the pulse. I can feel the pulse from my axillary artery. So that's telling you where the axillary artery is. Deep compression there, you can push the artery against the humerus. And I can feel, after doing that for a few seconds, like I can feel the different flow. sometimes more proximal compression is necessary. If you need to compress more proximally, the origin of the axillary artery can be compressed by pushing downward against the first rib. So downward pressure in the angle between the clavicle and the attachment of the sternocleidomastoid will allow you to compress this first area right where it begins against this first rib. The axillary vein follows a really similar pathway to the axillary artery as far as the location of it. The axillary vein is formed by the union of the brachial veins and the basilic vein at the inferior edge of the teres major. So you see that here. You see the basilic vein coming at the pinky side, and then it merges with the brachial veins, which were deeper and running up along the humerus. That forms the axillary vein. The axillary vein continues, and at the lateral border of the first rib, right, same as where the axillary artery ended or bounded, at the lateral border of the first rib, it's joined by the cephalic vein, and they become the subclavian vein. And you can see that here, the cephalic vein, which was coming up the thumb side, merges, and then the axillary vein becomes the subclavian vein. Right, you see here's the internal jugular coming down. They merge and become the brachiocephalic. This is a very simplified version that allows us to see like the major veins merging. The veins of the axilla are much more numerous than the arteries of the axilla. They're also highly variable, and they frequently anastomose with each other. So if you look at this picture over here, that's a bit more realistic. It's a little bit messier than some of the diagrams and models make it seem. Here you can see the axillary vein as it heads underneath the pectoralis minor and towards the arm, or into the arm. The axillary vein, you can see from this, is really close to the surface. There is not much tissue in some of these areas between the vein and the surface of the skin of the body. It's also really big. So the axillary vein is highly exposed and can be injured. The problem with injuring or puncturing the axillary vein is one, profuse bleeding. It's a really big vessel, so it does bleed quite a bit. But also the risk of air emboli entering into the bloodstream. So when air enters the bloodstream, it acts as an embolus, just like a blood clot could be an embolus. And this traveling around the body, if this gets to the lungs, to the heart, it can be highly problematic and dangerous. There are numerous lymph nodes present in the axilla. There are 5 major groups of lymph nodes that are embedded in the axillary fat, and there are numerous nodes in each of the groups. So overall, there are quite a few lymph nodes present in the axillary region. The groups include the pectoral, the subscapular, or that's also referred to as posterior, humeral. Humeral nodes are also referred to as the lateral nodes, the central nodes, and then the apical nodes. So the pectoral nodes, as said, they're by the pectoral region. They're located in the medial wall of the axilla, and they mostly are not taking lymph from the arm. They're taking lymph from the anterior thoracic wall and the breast region. The subscapular or posterior lymph nodes are along the posterior axillary fold, the skin fold that's at the back of the axillary fossa. They are accepting lymph from the posterior or the back regions. They take lymph from the posterior thoracic wall and scapular region. So pectorals from the pectoral region, subscapulars from the scapular region. Getting to the arm, the humeral or lateral nodes are along the lateral wall just inside or just medial to the axillary vein. Most of the lymph from the upper arm is going to go into the humeral nodes first, and then it'll pass through a series of other nodes. But most lymph goes to the humeral nodes initially, except the lymphatics that accompany the cephalic vein. So the cephalic vein, remember, is up along the thumb side. The lymphatics that come alongside the cephalic vein are going to go into the apical nodes initially. They go straight into the apical. The central nodes are located deep to the pectoralis minor, near the base of the axilla, right where the axillary fossa is. These accept lymph from the pectoral nodes, the subscapular nodes, and the humeral nodes. So all of these first three pass their lymph into the central nodes. Then they pass it to the apical. So the apical nodes receive lymph from everywhere. All of the other nodes pass their lymph to the apical lymph nodes eventually. The apical nodes are located at the top of the axilla, which makes sense because the lymph flows right from the bottom and the lateral edges up towards the top. Again, they receive lymph from all of the other axillary nodes and then also from those lymphatics that float alongside the cephalic vein. These efferent lymphatics that leave the apical nodes, all of the apical nodes, their efferent lymphatics join together, and that forms the subclavian lymphatic trunk. Here you guys see the different nodes. Again, the subscapular nodes or posterior nodes, they're accepting lymph from the posterior thoracic wall and the scapula. The pectoral nodes or anterior nodes here are accepting lymph from the anterior thoracic wall and the breast. The humeral nodes or lateral nodes are accepting lymph from the arm, except for the lymph that's coming up alongside the cephalic vein. From there, these all go to the central nodes, which are a little bit higher up. And then from there, they go into the apical nodes. Enlargement of the axillary lymph nodes can occur whenever there is any sort of infection in the upper limb or scapular or pectoral regions of breast. Infection in these areas can cause inflammation of the nodes, so swollen, palpable, tender axillary nodes, which is lymphadenitis. Inflammation in these areas can also cause inflammation of the actual lymphatic vessels themselves, which is lymphangitis. When lymphangitis is present, signs are warm red streaks in the skin of the limb. So there are warm red streaks leading up to the lymph nodes themselves. When there's an infection in the arm or the upper limb, the humeral nodes are typically the first nodes involved because remember the humeral nodes are the first nodes that most of the arm drains into. And then after that, they go into the central nodes and then eventually into the apical nodes. So infection can spread beyond the humeral nodes if it's not treated. Infection in the pectoral region and breast can also inflame the axillary nodes because remember this drains into the pectoral nodes and then those eventually drain into the central and apical. So infection of the breast can end up inflaming the other nodes, the axillary region. Axillary nodes are a common site of metastasis of cancer of the breast for this exact reason. A lot of the lymph or fluid from the breast is drained into the axillary nodes. So it makes sense if cancerous cells break off from a tumor in the breast that they can make their way up to the axillary nodes. The brachial plexus refers to the network of nerves that supply the upper limb. The brachial plexus is formed by the union of the anterior rami from the C5 through T1 spinal nerves. The anterior rami of the C5 through T1 spinal nerves form the roots of the brachial plexus. These roots of the brachial plexus pass between the anterior scalene and middle scalene, along with the subclavian artery, and then unite to form three trunks in the inferior neck, which will then go in towards the arm. You can see that here. So here you can see the anterior scalene and the middle scalene. You can see the roots passing or emerging through these vessels along with the subclavian artery and then heading down towards the arm. The three trunks that are formed here in the inferior neck are the superior trunk, middle trunk, and inferior trunk. We'll see as we follow these nerves that they unite and branch several times as we progress from the spinal nerve towards the nerves in the arm. This is a nice schematic that kind of shows you this process. The roots are here in yellow. So you see the spinal nerves, right? It's from C5 down to T1. The roots are shown in yellow, and then you see the trunks are in this peach color. So the roots merge, right? And we end up with the superior trunk, the middle trunk, and the inferior trunk. And then we have divisions of those trunks. We end up with an anterior division and a posterior division. Here we just see the anterior division is this part here. The posterior division is deep to that. You see cords that form here in blue from each of those. And then finally, we have these terminal branches that end up forming the actual nerves of the arm. And I showed you when we looked at the cutaneous, or when we looked at the dermatomes, one of the picture next to it had a color-coded picture to show you where each of the nerves, the specific nerves, innervate. So this is showing you where those specific nerves are coming from, right? So the radial nerve, medial, ulnar, musculocutaneous, axillary, suprascapular, lateral pectoral. Here's where the actual nerves are coming from. So again, we have three trunks that form in the inferior neck. The superior trunk forms from the union of C5 and C6. So you see here, C5 and C6 merge to form the superior trunk. The middle trunk is just a continuation of C7. And the inferior trunk is from C8 and T1 merging. So those are the three trunks. Each of these trunks divides into an anterior and posterior division. And this happens right as they pass behind the clavicle. So again, these trunks then divide, right? And you see that we get an anterior division and a posterior division. Okay, again, an anterior division and a posterior division. The anterior divisions supply the anterior compartments of the upper limb. These are the flexors. The posterior divisions supply the posterior compartments, so the extensors. All right, so we had the roots, and they came together to form these trunks. The trunks split into either anterior divisions that go into the flexors in the front, or posterior divisions that go to the extensors in the back. The anterior divisions of the superior and middle trunks unite to form the lateral cord. The anterior division of the inferior trunk continues as the medial cord. The posterior divisions of all three trunks unite to form the posterior cord. These cords are named for their position relative to the second part of the axillary artery. Remember that the axillary artery has three regions, and those regions are just because of its relation to the pectoralis minor. So the first part's before the pectoralis minor, the second part's behind it, the third part's after it. So the cords are just named according to the lateral to this part of the axillary artery, or the medial or posterior to it. Again, the cords are shown in blue here. So the lateral cord, the posterior cord, and the medial cord. The cords then give rise to the terminal branches, right? The terminal nerves that then go innervate different parts of the upper limb. The axillary nerve, which contains fibers from C5 and C6, can be damaged due to trauma or when the surgical neck of the humerus is fractured. When the axillary nerve is severely damaged, this can result in paralysis of the deltoid muscle, the large triangular shoulder muscle. When the deltoid muscle is paralyzed, it tends to atrophy rather quickly, and it withers away, resulting in an asymmetry of the two sides of the body or the two shoulders. You lose the rounded aspect, and just inferior to the acromion, there's actually like a little hollow instead of a rounded out area. This can also produce a loss of sensation on the lateral side of the proximal arm. This is the area that's supplied by the superior lateral cutaneous nerve. The superior lateral cutaneous nerve is a branch of the axillary. A branch of the axillary artery. So when you disturb that or damage the axillary artery, the downstream branch does not work either. To test for injury to the axillary nerve, you can have a patient abduct their arm against resistance, starting at about 15 degrees. So abduct the arm, raise the arm up against resistance, and they will not be able to do it if the axillary nerve has been damaged. The reason that we start at about 15 degrees, not completely against the arm, is because the supraspinatus, which remember is one of the rotator cuff muscles, the supraspinatus will help out with that first 15 degrees. So by starting at about 15 degrees, you're relying solely on the muscles innervated by the axillary nerve. There are multiple variations in the brachial plexus that can occur. Typically, the brachial plexus arises from the anterior rami of the C5 through T1 spinal nerves. This set of spinal nerves, or the brachial plexus, can move up in the spinal cord or it can move down in the spinal cord. So a prefixed brachial plexus is when it's sooner than it should be, or it's up higher than it should be. So the brachial plexus moves up a notch on the spinal cord, and it goes from C4 to C8. So it's actually higher, or originates higher than it normally would. Post-fixed brachial plexus is when the brachial plexus comes later. It's down lower than it should be. So everything moves down a notch on the spinal cord. So the post-fixed brachial plexus originates from C6 to T2 spinal nerves. With a post-fixed brachial plexus, it's pushed downward. It provides or creates some compression of the nerves, and the brachial plexus gets compressed against the first rib as it tries to squeeze through into the axillary region, and this can cause neurovascular symptoms in the upper limb. Any disease or damage or infection in the lateral cervical region or the axilla can damage the brachial plexus. Damage to the brachial plexus results in anesthesia and paralysis of the arm. So anesthesia is just a loss of cutaneous sensation. If you can't carry those sensory signals up through the brachial plexus to the CNS, then you don't feel them. There's no cutaneous sensation. Paralysis is when you can't bring motor signals through the brachial plexus down to the muscles of the arm. Complete paralysis is when there's no movement whatsoever. There can also be partial paralysis. Sorry, this should say partial. Partial paralysis is when movements are weaker than on the unaffected side. Signs and symptoms of brachial plexus damage or injuries just depends on the part of the plexus that gets damaged. Injuries to the superior plexus, so injuries to the C5 or C6 spinal nerves, are caused by an excessive angle between the neck and the shoulder. Right? So when the neck is pulled this way and the shoulder is pushed down, and that angle between the two is overstretched or excessive, that can damage the superior plexus. This can be caused by a couple different things. It's common when patients are thrown from a motorcycle or a horse. They are flying and moving in a forward motion, and the shoulder hits something, the ground or a tree, and the body keeps moving. So they get pulled or stretched too much in that angle. This can also occur during birth. When the baby's coming out, if the head is pulled too much to one side or one way while the shoulder is stuck in the birth canal, then that can create excessive stretching there in that angle, and that can damage the superior nerves of the brachial plexus. The brachial plexus can also be damaged due to just chronic microtrauma. This happens when people carry heavy backpacks, really heavy backpacks all the time. The backpack straps are just hitting on that brachial plexus area, and then they start to cause inflammation and trauma to the superior trunks. Chronic microtrauma can cause sensory deficits in the radial and musculocutaneous nerves, and this is progressive. Symptoms of injury to the superior plexus include Herb Duchenne palsy. Herb Duchenne palsy is a paralysis of the shoulder and arm muscles that are supplied by C5 and C6. The arm tends to be in this resting position right here. So the arm is adducted, it's up against the body and medially rotated. So instead of, like nice relaxed arms, palms forward, like anatomical position, the arm is completely adducted and rotated in like this. You can kind of see his hand towards the back like that, and elbow is extended. There's also a loss of sensation in the lateral upper limb. Again, the lateral limb is the area supplied by C5, C6 nerves. Injuries to the inferior plexus, this is sometimes referred to as clunky paralysis, occur when there's damage to C8 and T1 spinal nerves. This is caused by the arm suddenly and forcefully getting pulled up superiorly. This happens, for example, like when someone's falling and they grab something to try to catch themselves, like as you see here. This is an extreme pulling of the arm upward. Again, this can happen during birth as well. If the arm comes out before the head, you see the arm getting pulled out through the birth canal. This can also cause damage to the inferior brachial plexus. Symptoms of this are the short muscles of the hand get affected, and this produces a claw hand, or kind of like flexed fingers all the time.